The title of this talk is Demyelinating Disorders. The talk will be conducted using conversational and question and answer formats. These are the class objectives. You do not need to read them. We will use them to chart our talk. The first question is, which of the following structures is not myelinated at birth? A. Dorsal brainstem. B. Posterior limb internal capsule. C. Peripherolandic gyra. D. Anterior temporal and frontal U fibers. The age when a system or an area within a system is considered myelinated depends on the method being used to judge myelination. The most often quoted histological study about patterns of myelination was published by Yakovlev and Lecour in 1967. This publication has been the source of multiple charts correlating chronological age with age of myelination of the different structures. The chart we're about to build is an adaptation from that reference. It looks at fetal months, years, and to second and third decades. Motor roots start maturation at about 4th month of gestation and are fully myelinated by 1 month of age. Sensory roots maturation starts at about the 6th month gestational age and are fully myelinated by about 7 months. Somatosensory radiations, that is, sensory fibers going from the thalamus to the postcentral gyrus of the cerebral cortex, start maturating at about 7 month gestational age and are fully maturated by 2 years of age. Motor tracts follow a more or less similar temporal course of myelination. Optic radiations are peculiar. They start maturing by 8 months gestational age, but do so quickly, so by 6 months they are mature. Reticular formation starts myelinating just prior to birth and do not reach maturity until sometimes in the 2nd decade of life. The great cerebral commissure, as the corpus callosum, start myelinating shortly after birth and reach full myelination by 8 to 9 years of age. Association fibers are still maturing during the 3rd decade of life. Although the original studies looking at myelination were histological, MRI is by far a more applicable method to study myelination. Most often used modalities for this purpose are T1 and T2 sequences. In general, neonates at term show myelination at the dorsal brainstem, the posterior limbs of the internal capsule, where the somatosensory fibers going from the thalamus to the postcentral cerebral gyrus are, but they show no maturation in the anterior capsule. Another area where myelination is present in the newborn is the peripherolandic gyra. Notice that the frontal and posterior region of the central semiovale are not myelinated as compared to the peripherolandic area, which is whiter. At 19 months, as indicated here, most of the brain appears to have some myelination. The areas with no myelins are the anterior temporal and frontal U fibers, as you can see in these frames. So the answer to this question is D. Next question. Which of the following conditions is not considered an inborn error of metabolism? A. Metachromatic leukodystrophy. B. Globoid cell leukodystrophy. C. Adrenoleukodystrophy. D. Progressive multifocal leukoencephalopathy. In this question, we name 4 conditions. 3 of them I have already mentioned in a prior talk. 2 of those 3 are lysosomal disorders. Lysosomes, as you know, are cellular organelles. The function of these organelles is to degrade complex structures, including glycoaminoglycans, formerly known as mucopolysaccharides, sulfatides, gangliosides, and sphingomyelin. Lysosomes also degrade globoside, a compound found in red cells, heart, lung, liver, kidney, and endothelium. Two of the conditions listed in this question involve the catabolism of cerebroside sulfate, hence we will briefly review it. In this frame, I have represented the pathway and three enzymes involved in the degradation of cerebroside sulfate. A failure in the first step involving aryl sulfatase produces metachromatic leukodystrophy. Deficiency of galactocerebroside produces Krabbe disease. In Krabbe disease, the increase in psychosin leads to the formation of globoid cells in the central nervous system. Hence, the term globoid cell leukodystrophy is often used when referring to Krabbe's disease. The third condition that occurs as a consequence of abnormal catabolism of sulfatides involve ceramidase. This condition is named Farber disease. In addition to the two lysosomal disorders mentioned in this question, metachromatic leukodystrophy and globoid cell leukodystrophy, a third condition mentioned in this question we have previously addressed. This condition is adrenoleukodystrophy. Adrenoleukodystrophy is a peroxisomal disorder. Adrenoleukodystrophy is an X-linked disorder which is secondary to a mutation in the ABCD1 gene and results in peroxisomal beta oxidation defect and the accumulation of saturated very long-chain fatty acids in all tissues of the body. This accumulation leads to the production of reactive oxygen specimens that harm mitochondria and endothelial reticulum, leading to cellular death in multiple organs. This usually translates into early symptoms of white matter neurodegeneration and adrenal insufficiency. The fourth condition mentioned in this question we have not previously addressed. This condition is progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy is a demyelinating condition implying that normally formed myelin is destroyed, unlike in leukodystrophy where myelin is badly formed. Some authors use the term primary myelin disorders for those due to poor formation and secondary myelin disorder for those where initially well-formed myelin is destroyed. Progressive multifocal leukoencephalopathy is a reaction to a previous papavirus infection. Progressive multifocal leukoencephalopathy involves immunocompromised patients afflicted by conditions such as AIDS, lymphoma, sarcoidosis, and lupus, and in patients on immunosuppressive therapy, including those patients taking natalizumab, a monoclonal antibody used for the treatment of multiple sclerosis. The clinical manifestations of progressive multifocal leukodystrophy vary depending on the area of the brain most affected. Frequently, manifestations are blindness, dementia, and paresis. MRI of the brain often shows demyelination involving the U fibers. U fibers are those fibers that connect one gyro with the neighboring gyros. Brain biopsy shows demyelination without inflammatory response, especially in the subcortical white matter, as expected. Histological staining using papavirus stain shows significant oligodendroglea involvement, and electron microscopy can detect the virus as little round balls, as you can see in this frame. This frame that you're looking at is a specimen from animal, not from human. So the answer to this question is D. Next question. 20 years old girl, 7 days after chickenpox, became obtunded, right hemiparetic, and aggressive. See CT scan below. What is your diagnosis? A. Acute disseminated encephalomyelitis. B. Acute hemorrhagic leukoencephalitis. C. Neuromyelitis optica. D. Progressive multifocal leukoencephalopathy. 4 conditions are mentioned in this question too. The first one is acute disseminated encephalomyelitis, usually called ADEM. ADEM is an acute immune-mediated demyelinating disorder. ADEM may follow viral infection or immunization with live or kill virus vaccines such as influenza and rabies. ADEM occurs with fever, meningeal signs, and at times stupor. This presentation often warrants performing a spinal tap after excluding the possibility of increasing intracranial pressure. CSF in ADEM demonstrates increased cell count in the range of 20 to 200 monocytes, an increase in total protein, an increase in gamma globulin, but no oligoclonal bands. The term oligoclonal band is used to indicate the presence of at least 2 bands of IgG with a specialized electric points seen in the CSF with no corresponding band present in the serum. It indicates that there is intrathecal B lymphocyte production of IgG. As you can see in this example, no oligoclonal bands are present. EEG in patients with acute disseminated encephalomyelitis usually shows generalized asynchronous delta activity. More prominent slowing with higher voltage wave are present in this study on the left than on the right, but the opposite can also be true. MRI shows multifocal areas of hyperintensity involving the cortex, white matter on both hemispheres, and the thalamus, as well as many other cerebral areas. In the spinal cord, we can also find evidence of white matter abnormality. In this MRI, you can see white area flanked by gray rims that represents demyelinating abnormalities. Prognosis of this condition is guarded. On the good side, it is a monophasic condition. On the bad side, full recovery occurs only in 50% of the cases, and the mortality rate is about 20%, as it occurred in a case described by Hashim in 2011. These brain pictures are from biopsy-proven acute demyelinating encephalomyelitis. You can see in this specimen congested superficial veins in the cerebral hemispheres, cerebral edema, hypothalamic bleeding, and brainstem bleeding in multiple areas. Histologically, studies of the hypothalamus in this patient showed typical findings of acute disseminated encephalomyelitis. These typical findings were multiple foci of hemorrhage indicated by the green arrows and perivascular lymphocyte coughing indicated by the yellow arrow. The second condition mentioned in this question is acute hemorrhagic leukoencephalitis. As you saw in the last case, the one we just looked at the autopsy, bleeding occurs in ADEM. Hence, the boundaries between acute disseminated encephalomyelitis and acute hemorrhagic leukoencephalitis are not well defined, to the point that most neurologists I know consider acute hemorrhagic leukoencephalitis a very acute form of acute disseminated encephalomyelitis and use this term, that is acute hemorrhagic leukoencephalitis to refer to cases when the post-infectious nature of the condition is certain and the hemorrhagic lesion is single or contiguous resembling a mass. Acute hemorrhagic leukoencephalitis is thus preceded by a viral infection. Manifestations are often sudden. You think the viral infection is getting better, and all of a sudden the patient gets worse. Focal neurological findings as well as signs of increasing intracranial pressure are usually present. A CT done in an emergency basis. Remember that before doing a spinal tap in patients with a focal neurological finding suggestive of a brain problem, you must do an image study, and CT is usually faster and more readily available at most institutions than MRI. Hence, it is often preferred. In addition, CT is a good method to detect bleeding and exclude conditions that place the patient at risk for cerebral herniation. For example, in this CT of a patient diagnosed with acute hemorrhagic leukoencephalitis, you can see hemorrhage surrounded by edema. Hence, doing a spinal tap in this patient will be highly risky, and it should be avoided. The third condition mentioned in this question is neuromyelitis optica. This condition involves the optic nerve and the spine. It is also called Devick's disease. Optic nerve involvement produces rapid visual loss, often bilateral and occasionally total. This is a representation of a normal visual field. In gray, the black dot corresponds to the blind spot. At times, ocular manifestation in patients with neuromyelitis optica begin as reduced acuity and bilateral central scotoma, here indicated by the violet area. This quickly progress, sometimes asymmetrically, to produce bilateral total blindness. Ophthalmoscopic evaluation may reveal papillitis, as in this case, due to involvement of the papilla, which is in front of the cribriform plate, but more often the fondi is completely normal because the optic nerve is involved in the area behind the cribriform plate. This is called retrobulbar area. In addition to optic nerve involvement, spinal cord involvement is part of this condition, hence the name neuromyelitis optica. This is an MRI of the spine of a patient with neuromyelitis optica. In it, you can see a large spinal cord segment involved. It extends from the lower cervical to the thoracic spine. The lesion, as you can see, is rather long, extending beyond the area captured by this image. Spinal cord manifestations usually appear hours, days, or even weeks after ocular symptoms. They are usually characterized by signs and symptoms of extensive transverse myelitis involving 3 or more vertebral segments, as you saw in the MRI I just showed you. Frequent manifestations consist of tetraplegia and paraplegia, which may involve the region below or above the umbilicus. The umbilicus usually corresponds to thoracic 10 spinal segment. Urinary retention is also a frequent finding in these patients. Lumbar puncture in patients with neuromyelitis optica usually reveals increased cell count, usually over 1,000 monocytes, high protein, increased gamma globulin, but no oligoclonal bands, as you can see in this CSF study compared to plasma. Recent studies on patients with neuromyelitis optica have revealed that this condition may be a manifestation of at least 3 different pathological processes. Some patients with neuromyelitis optica have antibodies against astrocyte water channels protein aquaporin 4. This is the most frequent encountered association. Other patients have antibodies against myelin oligodendrocyte glycoprotein, and a third group of patients have no antibodies. Prognosis-wise, this is usually a monophasic condition. Full recovery is expected in 60 to 70% of patients. Before starting our discussion of the most frequent demyelinating condition that affects humans, that is multiple sclerosis, I'd like to tell you about two other demyelinating conditions. One of these conditions is transverse myelitis. This is an important condition because it may be due to herpes simplex infection, a treatable condition. Patients with transverse myelitis due to herpes usually have a positive PCR for herpes in the CSF. Clinical manifestations are those of spinal involvement, mainly tetraplegia or paraplegia, and urinary incontinence. Dependent reflexes are decreased in the acute phase but increase in the chronic phase of this condition. The second condition is also important because in most instances it can be avoided. This condition is called osmotic demyelination syndrome or central pontine myelinolysis. We could start understanding this condition by mentioning the death of astrocytes. The astrocyte died because of intracellular dehydration. The dead astrocyte fails to guard the blood-brain barrier as they usually do, and blood-brain barrier disruption occurs. The breakage of the blood-brain barrier exposes glial neurons normally protected from the general milieu to glial neuron noxious elements, which lead to demyelination. The avoidable triggering factor is too fast correction of hyponatremia. It is actually the relatively hypertonicity of the fluid bathing the astrocyte that sucks the fluid out of the astrocytes and kills it. High levels of glucose, especially when rapid shift in blood glucose take place, can have the same effect on astrocytes. This is the typical MRI we see in association to central pontine myelinolysis, showing the central pontine location of demyelination as it's implied by the name of this condition, central pontine myelinolysis. Clinical manifestations are expected by the location of the pathology produced. So we usually find findings of lower pons involvement, tetraplegia, and at times locking syndrome. Remember the following rules. From low to high, your pons will shrink and die. That is, osmotic demyelination will happen. Low refers to hyponatremia and high to hypernatremia. From high to low, your brain will swell and blow. This refers to cerebral edema and herniation. So the answer to this question is B. Next question. Multiple sclerosis affects women more than men. A true, B false. Risk factors for multiple sclerosis, better known as MS, are very interesting and some are avoidable. The first one is geography. Individuals born and living close to the equator are less likely to develop MS. This may be due to the protective effects of ultraviolet B light, likely related to the effect of ultraviolet B light to promote the formation of vitamin D. If a patient from a low-risk geographical region moves as an adult, even as a young adult, to a geographical high-risk area, that individual keeps the risk of the place that he was born at. Patients born at high-risk area, regardless of the parent geographical birth region, are at high risk for multiple sclerosis. The important point here is that environment factor trumps genetic factors when dealing with MS. Never having been infected by Epstein-Barr virus decreases the chances of getting MS. Smoking tobacco increases chances of MS, but chewing tobacco does not. women are more often affected by MS than men. Being human leukocyte antigen DRB1 1501 increases chances of MS. Being ALA O201 protects against MS. So the answer to this question is true. Next question. Lermite sign indicates spinal lumbar involvement. A true, B false. Jacques-Jean Lermite described this sign. He noticed and described that flexion of the neck in patients with multiple sclerosis produced electrical shock-like sensation that extended down the spine and at times went into the limbs. The cause of this sign is demonstrated in this MRI. Notice the level indicated by the arrows. On the top arrow, the space between the spine and the bone is wide, but it suddenly narrows as indicated by the lower white arrow. The magenta arrow introduced points to the area where the spine is in close proximity with the bone. Lermite sign is thought to be produced by the compression of the posterior column against the posterior vertebral elements in the cervical spine. So the answer to this question is B. Next question. Oth-Hoff phenomenon is the worsening of neurological symptoms in multiple sclerosis triggered by heat. A true, B false. In 1890, Oth-Hoff described exercise-induced amblyopia in multiple sclerosis patients. Later, it was noted that it was not the exercise but the fact that during exercise a person's temperature goes up what caused the amblyopia. 6 decades later, in 1950, the hot bath test was developed based on this phenomenon and was used as diagnostic test for multiple sclerosis. Doctor would ask their patient suspected of having MS to take a hot bath and see if symptoms appears or gotten worse. Patient with MS would have the symptoms worsen by this procedure. The bottom line in 2020 is that the Oth-Hoff phenomenon refers to a temporary, short-lived, usually less than 24 hours, stereotype worsening of neurological findings among multiple sclerosis patients in response to an increase in core body temperature. Hence, it is important to let MS patients know that too much exercise, especially outdoors, using hot blow hair dryers, taking hot showers, and having high temperature makes MS symptoms worse and for them to avoid them. So the answer to this question is A. Next question. The McDonald criteria allows for MRI scan evidence of development of new lesions to lead to the diagnosis of multiple sclerosis after a single clinical episode. A true, B false. The diagnosis of multiple sclerosis is challenging, not only because of the many symptoms it can present, but because of the very temporal course it may follow. We can arbitrarily signal out 4 different courses. Number 1, patients with multiple sclerosis often have a relapsing and remitting course throughout the full course of their illness. Recovery is usually complete. The aim of treatment of these patients is to prevent further episodes. In patients following this course, the diagnosis of MS on clinical ground consists of finding 2 symptoms reflecting 2 separate anatomical locations, for an example involving the cerebrum and another the cerebellum or brainstem, 2 separate attacks with onset at least 1 month apart. Symptoms must involve the white matter. The patient must be between 10 and 50 years of age. MS in patients less than 10 years of age can occur but cannot be diagnosed on clinical grounds alone. We need in these patients to have complementary MRI, spinal tap, and often visual and somatosensory evoked responses. Another criteria needed to make the diagnosis of MS clinically is objective evidence of neurological deficit. That is, the presence of abnormality during the neurological exam. And most importantly, no other medical problem can be found to explain patient's condition. The second type, of course, is called secondary progressive. After a few bouts of intermittent attacks, baseline normality is not reached, and subsequent episodes add to the baseline morbidity, as represented in this chart. Some authors mention that this conversion from the disease being relapsing and remitting to progressive usually occurs 6 to 10 years after the onset of disease, while others mention that the shift occurs later. About 20% of untreated patients follow this course. The clinical criteria for the diagnosis is in this group the same as the one that we previously described. The third type of clinical course is called primary progressive and occurs in 15% of patients that ultimately are diagnosed with MS. The diagnosis of MS in patients following this course cannot be based on clinical criteria alone. In these patients, there is never a relapsing course but a progressive deterioration. In this type of presentation, after the first symptom, there is never a return to baseline. The diagnosis in these patients cannot be made solely reliant on clinical findings as we just previously mentioned. The diagnosis of MS in these patients relies on finding being present and progressive for 1 year. Findings must be adjudicated as a result of brain and spinal plaques in the white matter. CSF must demonstrate oligoclonal bands, and other diagnoses must be excluded. And the fourth course is called progressive relapsing. Few patients with MS follow this course. In this type of progression, the disease starts progressively, but suddenly there is punctuated by acute relapses. The criteria for the diagnosis is the same as the patient with primary progressive disease. So what is the McDonald criteria? The McDonald criteria was started as a research criteria, but it's now used clinically. It allows to diagnose MS during or after the first episode without waiting for a second episode or for progression. It is based on using MRI evidence of prior lesions consistent with MS to diagnose multiple sclerosis after or during the first symptoms clinically believed to be due to MS. This criteria includes that alternative diagnoses have to be excluded prior to using it. So the answer to this question is true. Next question. Which of the following conditions often mimics multiple sclerosis? A. Systemic lupus erythematosus. D. Sarcoidosis. C. Vitamin B12 deficiency. D. All of the above. Regardless, the criteria used to diagnose MS, one statement is always present. No other medical problem can be found to explain the patient's condition. For the clinician, the problem is how far to go looking for other medical problems. In other words, how far to test looking for other explanation for the patient's current findings. Hence, it is important to know what diseases have in the past fooled doctors to believe their patient had MS and later on turn out to have something else. The term used to label such conditions is MS mimickers. This list includes inflammatory conditions such as lupus, polyarteritis nodosa, and Behçet's disease. Behçet's disease is characterized by uveitis and recurrent oral and genital ulcers, and at times neurological findings. Here you can see the MRI of a patient with Behçet's disease, and also a photograph of the oral ulcers the patient presented. Never forget to check the mouth of a patient presenting with neurological deficit. If you do forget, you may miss this condition. Most patients seek medical attention for genitalia ulcers and for uveitis, but forget to tell the doctors about oral ulcers. MS mimickers also include isolated cranial disorders such as AVM, as you can see here, and meningiomas. Also consider granulomatous disorders such as sarcoidosis and Wegener's granulomatosis. Look at this MRI of a patient with Wegener granulomatosis. Notice the multiple lesions separated by normal brain, which is one of the characteristics of MS. Hence, always consider this condition, especially when the person is relatively young. Also consider the possibility of a spinal cord and foramen magnum lesions, extrinsic and intrinsic CNS tumors, Lyme disease, especially if the patient is from or recently has traveled to a high-risk area for Lyme disease, here represented in blue. Also consider vitamin B12 deficiency. B12 deficiency is an easy diagnosis, most of the time made just by looking at the blood smear and finding megaloblastic anemia and hypersegmented neutrophils. And last but not least, consider the possibility of acute disseminated encephalomyelitis and all related conditions we addressed at the beginning of this talk. So remember, when you see an unexplained neurological finding, that it may help you to organize them in the following way. You may be dealing with a rare finding of a common disease, a common finding of a rare disease, or a rare finding of a rare disease. Think first treatable conditions, after think frequency. So the answer to this question is D. Next question. Patient with MS being asked to look at the target. Please take a few seconds to look at this drawing and choose a likely diagnosis. A. Extranuclear ophthalmoplegia. B. Intranuclear ophthalmoplegia. C. Nuclear ophthalmoplegia. D. None of the above. Every conceivable central nervous system complaint has been described in patients with multiple sclerosis. The most frequent initial symptoms of multiple sclerosis are sensory disturbance, retrobulbar neuritis, limb weakness, diplopia, vertigo, ataxia, and sphincter disturbances. Diplopia, although not among the most frequent, when present in the right setting, is very suggestive of multiple sclerosis. Diplopia in a patient with MS often has the presentation illustrated here. The eyes look fine in the primary position. When looking to the target on the right eye looks to the right very well. That is, there is normal right eye abduction. The left is unable to adduct, that is, not going past the midline. This finding should make you think of the possibility of left medial rectus not working, injury to the left partial third cranial nerve fibers going to the medial rectus muscle, and left internuclear ophthalmoplegia. Then you ask the patient to look to the left and both eyes move well. This supports the three possibilities we listed. Now you ask the patient to converge, and the left eye that could not adduct before now does so. This rules out left medial rectus problem and partial left cranial nerve 3 injury, thus establishing the diagnosis of left internuclear ophthalmoplegia. Internuclear ophthalmoplegia is one of the most common characteristic signs of multiple sclerosis. Here I have introduced the vestibular pathway for eye movements. The system connects from the vestibular apparatus to the ipsilateral vestibular nucleus, from the vestibular nucleus to the contralateral parapointed reticular formation, from the parapointed reticular formation to the ipsilateral in relation to the parapointed reticular formation cranial nerve 6 nucleus, from the cranial nerve 6 nucleus via the crossing of medial longitudinal fascicles fibers to the contralateral cranial nerve 3rd nucleus, and from there to via the 3rd cranial nerve to reach the medial rectus muscles. I will now introduce the connections in charge of saccadic movements that arise from cortical area 8 and land in the parapointed reticular formation. And now I have added the convergent pathway ending upon the 3rd cranial nerve nucleus and bypassing the parapointed reticular formation and the medial longitudinal fascicle. This explains why a lesion in the left medial longitudinal fascicle does not impair abduction of the left eye in this case due to conversion. It is so because the conversion pathway bypasses the parapointed reticular formation and the medial longitudinal fascicle, going directly to the 3rd cranial nerve nucleus. The lesion we have just described in the medial longitudinal fascicle is called an internuclear ophthalmoplegia. It is called so because it occurs between the 6th and the 3rd cranial nerve nucleus. So the answer to this question is B. Next question. Multiple sclerosis pathology has two phases, an initial inflammatory phase followed by a degenerative phase. A true, B false. The puzzle of MS has not been solved. We do not know why it happens, why exacerbations occur on one day and not the other, nor what triggers the first episode. We know that early on, T cells gain entry to the CNS due to disruption of blood-brain barrier. The reason for the disruption of the blood-brain barrier is unknown. We know that T cells wrongly identify myelin as foreign and attack it. We think we know that T cells secrete cytokines and that B cells produce antibodies that attack myelin and oligodendrocytes. We know that macrophages destroy myelin and oligodendroglia. These processes are probably responsible for the perivascular infiltration of the central nervous system by monocytes and lymphocytes present early in patients with MS, indicating an inflammatory phase, and for the well-delineated relatively acellular plaques present in the second phase of this condition. It appears that the axonal loss in this area is the cause of the neurological deficit in patients with MS. These plaques represent the degenerative phase of MS. These plaques are more frequent in some regions of the nervous system than in others. In the brain, in the periventricular area, as you can see here, close to the temporal horn of the lateral ventricle, here close to the lateral ventricle, and here in the temporal horn of the lateral ventricle in the opposite hemisphere. Spinal cord lesions of the same size tend to produce more symptomatology than those in the brain. This is due to the concentration of pathways and neurons in a smaller volume encountered in the spinal cord. A relatively small lesion isolated to the posterior horns of the spinal cord can produce loss of all sensation modalities in a root distribution, resembling a spinal nerve lesion, as illustrated here. A similar plaque anterior to the anterior horn of the spinal cord may result in lower motor neuron signs restricted to one root, which will manifest by weakness and atrophy with a root distribution. Larger lesions as the one indicated here may involve the pyramidal tract, as you can see here on the right, the spinothalamic tract on the left, and the posterior column fibers from both lower extremities in the back. This is an example of involvement of the lateral columns and sparing of the posterior columns and anterior columns in a patient with MS. And in this specimen, you can see a different distribution of the affected fibers. Notice that the demyelinated white matter usually stains similar to the color of the gray matter using this type of stain. So the answer to this question is true. Next question. MRI with and without contrast can be used to recognize aptic lesions in patients with MS. A, true. B, false. MRI findings are heavily relied upon for the diagnosis of MS. MRI often shows lesions separated by space and time. Here you can see periventricular and parenchymal lesions, active lesion consisting of a white core surrounded by a dark circle, and an old lesion. Paramagnetic contrast gadolinium MRI will show, in many instances, active inflammation. A T1 MRI with no contrast shows multiple lesions, and as you can see, they all tend to look about the same. Using contrast, some lesions enhance. Those lesions that capture contrast are active, hence considered new. The presence of an all non-contrast enhancing lesion and a contrast enhancing lesion indicates temporal separation. MRI of the spines are also helpful to diagnose MS. Here you can see the white streak inside the cord indicating a lesion, and here another. Notice that their size is small compared to those we saw in patients with Devig's disease. So the answer to this question is true. Next question. Which of the following CSF findings suggest an alternative diagnosis in a patient with suspected multiple sclerosis? A. White blood cell count above 1,000 mononuclear cells per square millimeter. B. Increased gamma globulins. C. The presence of myelin basic protein. D. The presence of oligoclonal bands. Patients with suspected multiple sclerosis often undergo spinal tap. Remember that the ideal location for a spinal tap is between L3 and L4 posterior vertebral processes. Patients with MS usually have less than 25 white blood cells and all are monocytes. Total protein may be as high as 100. Gamma globulins tend to be up in over 50% of the cases. Myelin basic protein is present. Oligoclonal bands are also present. Oligoclonal bands in the CSF are usually absent in many of the conditions we have previously described as MS mimickers, but they tend to be present in MS. Notice that although difficult to see, this smear has alternating bands of dark violet here and here, separated by light violet bands here and also here. No such separation is present in the plasma. This is interpreted as there being oligoclonal bands in the CSF, and it is due to intrathecal production of gamma globulin. Oligoclonal bands aid in the diagnosis of MS. In the fourth edition of Neurology Secrets, they are considered reasonably sensitive and specific. And in the fifth edition of Neurology and Neurosurgery Illustrated, they are considered not diagnostic, and this book provides a list of conditions where they are also elevated. The list includes HIV infection, chronic meningitis, Lyme disease, neurosarcoidosis, neurosyphilis, and subacute sclerosing panencephalitis. Victor and Adams consider oligoclonal bands not specific and list 3 conditions indicated here as also having oligoclonal bands in the CSF. In this book, oligoclonal bands are considered gamma globulin produced inside the CNS, as it is in many other books. So the answer to this question is A. Next question. Unilaterally, right or left delay P100 indicates A. Optic nerve pathology, B. Optic radiation pathology, C. Lateral genicular pathology, D. Optic tract pathology. Visual evoked potentials measure the time it takes for light to reach the retina, which is instantaneous given the speed of light and the short distance from the light source to the retina, the time it takes for the retina to convert light into electricity, and the time it takes for electricity to reach the occipital cortex. This test is done by placing an electrode in the scalp in the area corresponding to the occipital pole, a second electrode in the forehead, and a third electrode to serve as a ground at the vertex. This electrode array is necessary to register the potential generated by the light in the occipital electrode. Once the electrodes are connected, contrasting and alternating lights are presented to the retina, as shown here. This is usually done not using a single light source, but by using a checkerboard with alternating color squares presented to each eye individually. Normal conduction time is less than 120 milliseconds. Most people conductions fall at 100 milliseconds. Hence, this test is called P for positive polarity of the wave and 100 for the time it takes for the response to reach the occipital electrode. How does a normal study looks like? As we previously mentioned, we study one eye at a time. The eye not being studied is covered to prevent light stimulus from stimulating the retina. The checkerboard is turned on and the squares begin to alternate. As the square alternate, the retina gets stimulated. And 100 milliseconds later, a wave peak is recorded. Then we go to the other eye and do the same procedure. And we see a similar wave. So what happens when the right optic nerve is affected? As I have indicated here by the red line crossing the right optic nerve, as you can see. In this case, when examining the left eye, the time to the peak of the wave will be normal. When the right eye is tested, the peak of the wave will be delayed because conduction of electricity through the affected optic nerve is slow. Remember, demyelination slows conduction. Now let's look at what would happen if the lesion is posterior to the chiasm. Let's say on the right, either in the tract, lateral geniculate, or radiations. I will use the example of a lesion being in the radiations. Right optic radiation lesion, as indicated here, does not interfere with the conduction of electrical activity produced by stimulation of the temporal retina of the left eye. But it does interfere with the conduction of electricity produced by stimulation of the left eye nasal retina, since the pathway of electricity goes through the right optic radiation, and as a consequence, it is delayed, producing a delay P100 as indicated here. When testing the other eye, as I am illustrating in this frame, the activity produced as a result of nasal stimulation of the right eye is not affected by the lesion in the right optic radiations, but the conduction of the activity generated in the temporal retina of the right eye is delayed, producing a late P100 as a consequence of this delay, as you can see in this frame. The bottom line of visual evoked potentials is that visual evoked potentials normal in one eye and delay in the other indicates a prechiasmatic pathology, that is, a pathology present in the optic nerve. Visual evoked potentials delay in both eyes indicate a postchiasmatic lesion, either in the optic tract, lateral geniculate, or optic radiations. So the answer to this question is A. Next question. A delayed P37 posterior tibial nerve evoked potential and a normal P20 median nerve evoked potential indicate pathology at A. T10, B. C3, C. the pons, D. the midbrain. In this frame, you can see represented the main trajectory from the skin to the cerebral cortex traveled by impulses generated by electrical stimulation of the skin innervated by the posterior tibial nerve and the median nerve. When the posterior tibial nerve is stimulated, electricity travels through the posterior tibial nerve fibers and enters the spine in the lumbar region. From there, the brain recorded activity ascends in the ipsilateral posterior column until it reaches the nucleus of gracilis. Then fibers from the neurons at this site form the arcuate fibers that cross to the opposite side and ascend in the medial lemniscus, reaching the thalamus, ventral posterior lateral nucleus. Neurons from this nucleus reach the mesial surface of the postcentral gyrus, generating a wave called P37 that will be recorded by an electrode placed at the scalp contralateral to the arriving stimulus. Because the electrical vector created by the activity from the mesial cerebral cortex is inclined towards the opposite hemisphere. So we have looked at the evoked potential produced by posterior tibial nerve stimulation. Now let's look at what happens with median nerve stimulation. When the median nerve is stimulated, electricity travels through its fiber and enters the spine in the cervical region. From there, it ascends in the ipsilateral posterior column until it reaches the nucleus cuneatus. Then fibers from neurons at the site form the arcuate fibers that cross to the opposite side and ascend in the medial lemniscus to reach the thalamus, again the ventroposterior lateral nucleus. Neurons from this nucleus reach the lateral surface of the posterior central gyrus as indicated here, where they are captured by an electrode. This wave is called P20. A lesion at the level of T10 will delay the conduction of the leg impulses. Median nerve generated activity will not be affected by a T10 lesion. Hence the answer to this question is A. Next question. Treatment for multiple sclerosis include the use of dash. A. Disease-modifying agents. B. IV steroids. C. Symptomatic medications. D. All of the above. Treatment of multiple sclerosis include the use of disease-modifying agents such as beta interferon that helps to reduce inflammation and the body immune reaction. It may work at multiple levels. Glatiramer acetate that helps block immune system attack on myelin, and natalizumab, a drug designed to block the movement of possibly damaging immune cells from the bloodstream to the brain and spinal cord. IV steroids are used to treat exacerbations. And symptomatic treatment, some of the conditions frequently needing intervention are listed here, as well as the drugs used for them. Psychological support should also be provided. So the answer to this question is D. Thank you very much for your attention.